ahead and stop sharing my presentation, and I'd like to hand over to Dr. Rick Johnston from the JMP to tell us about what the data is for Washington healthcare facilities.
Yeah,
over to you.
Thanks so much, Lindsay. It's a pleasure to be here. First of all, can you see the screen that I'm trying to share?
Yes, we can. Looks great.
Okay, super. So I'm Rick Johnston. I'm with WHO in Geneva, and I co-lead the Joint Monitoring Program with Tom Slaymaker at UNICEF, who's also on the call today. Yeah, people could just mute their microphones if they're not speaking. I'm getting some noise. Well, the JMP has been publishing reports on Washington healthcare facilities since 2019. And today I wanted to share some of the highlights of the report that we published in August last year, which is the third global report now that we've published on Washington healthcare facilities since the first one in 2019. So let's see, there we go. Gosh, there we go. So this new report, well, it updates and supersedes the data from the early reports, including the 2020 Fundamentals First report. And that report was pretty short. It only included about 20 figures. It was one chapter in a part of a larger report that the JMP contributed. Whereas this 2022 report, it's a full-scale report. It's got about 80 figures, and that allows us to go into a lot more detail beyond just the basic indicators and explore, for instance, inequalities or things that go beyond the basic service levels, which we didn't have the time or the space to do in 2020. And one thing that I get excited about in this report is the amount of data sources that we draw on. It's expanded a lot. We had access to over 500 national sources of data, and most of these are healthcare facility surveys, but we also have several examples from routine management information systems, or MIS, and a small number of sector reports or other research studies. And together, these data sources represent assessments of at least 933,000 healthcare facilities. That's up from just over 500,000 in the 2019 baseline report. And we think that it's actually a larger number because some of the sources don't tell us how many facilities they sampled to collect their data. Well, for each of our reports, we make use of service ladders to monitor progress towards different levels of WASH services. So for households and schools, we have ladders for water, for sanitation and hygiene. We have those for healthcare facilities as well. But in addition, there are ladders for healthcare waste management and environmental cleaning, which are both related to hygiene and infection prevention and control, specific to healthcare facilities. So the ladders include definitions of the basic service level. That's the highest level that we track for global monitoring. But that doesn't mean that that's the highest possible level. These basic service levels really are quite basic. So we also highlight in our reports where data are available, examples of countries that are monitoring higher levels of service. Lower in the ladder, we try to distinguish between facilities that have no services at the bottom of the ladder there, and facilities that meet some but not all of the requirements for basic services, and we call those limited services. Now, this report had a special focus on infection prevention and control, or IPC. We're very excited about that. It was topical with the whole pandemic, but there are a lot of reasons why WASH and IPC are important for each other, and we wanted to explore those systematically. A lot of our audience come from more of a WASH background than a health background, so we wanted to point readers towards frameworks and resources from the health sector on IPC. For example, the IPC has what they call 8 core components of IPC programming, and one of them is about infrastructure, and it includes WASH services. So within the IPC literature, then, there are minimum requirements from an IPC perspective for each of those 5 service areas. So we reference those, we cite those in the report and try to find data examples of those. Also in 2022, there was an important global report on IPC, the one with the little blue tree there. And that included data from the first WHO global survey on IPC in healthcare facilities. So we also referenced that and show some of the WASH-related data from that report. Now, This figure shows bars from the 3 reports that we've published showing the numbers of countries that have data for the different basic service indicators, water, sanitation, hygiene, waste management, and environmental cleaning. And the different shades of gray represent different income level countries. You can see that there's a lot more data available from low and lower middle income countries than from especially high income countries. But you can also see that there's been a solid progression among the 3 reports. Data coverage is the lowest for environmental cleaning. That's the newest of the indicators, but it's really been increasing steadily from report to report. Now, the colored circles, they show the evolution in the proportion of the global population that has data. So if we look at water on the left, we can see that the number of countries with data on basic water services has increased from 38 to 52 and now 59. That's great. But the proportion of the global population with data hasn't really changed much. It's around 37%. And that's because the new countries that have been added were small in that case. But we do see strong growth in the population with data for the other indicators. And if we look at hygiene in particular, we see that it crosses above 30% for the first time in this report, at 35%. And that's important because the JMP has a rule where we won't publish regional or global statistics unless they draw on real data from at least 30% of the relevant population. So that means that we could, for the first time, produce a global baseline for basic hygiene services, along with regional estimates for 3 of the SDG regions, and for fragile contexts, and for least developed countries. In fact, we organized our report to lead with hygiene this time. We have started with water in the past, both because we have a new global baseline and because hygiene is so central to IPC with the special focus of the report. You can see the definition of the basic hygiene service up there. It's about having water and soap or alcohol-based hand rub at points of care, and also having water and soap available at or near toilets. So while it's good news that we have enough data to make a global estimate, that global estimate is actually pretty bleak, that just about half of healthcare facilities had a basic hygiene service in 2021. And that just means they had functional hand hygiene facilities at points of care and water and soap at toilets. It doesn't even mean that they were used, just that they were available. We can also see some important differences among the regions. For instance, in the 46 least developed countries, coverage is the lowest, with only about 1 in 3 healthcare facilities having a basic hygiene service. Now, the report and the individual country files can be downloaded from our website, washdata.org. But you can also make your own graphs on the website. I encourage you to visit it at the website above there. And this is an example of, it's called a rank chart for the basic hygiene services that shows that we had 40 countries with enough data to have basic hygiene services in healthcare facilities, ranging from a number of countries with universal coverage, 100% or nearly 100%, down to a few countries below 20%, and Niger even only at 4%. So there's a lot you can do by exploring that website to learn more about countries that you're particularly interested in. We also highlighted good examples, and of course, the COVID pandemic drew special attention to hand hygiene in healthcare facilities. And in Ghana, they have a very impressive routine MIS system called District Health Information System, DIMS, that's been collecting data on basic hygiene since 2018, so before the pandemic, when the global indicators were first defined. And this allowed people, the planners in Ghana, to know exactly which facilities did and didn't have basic hygiene services when COVID hit at the beginning of 2020. So the Ministry of Health used this data. They acted quickly to reinforce systems in healthcare facilities. They held trainings of IPC focal points, encouraged the use of simple hand washing devices, and made sure that water and soap were available when needed. And as a result, we could see coverage increase from 41% at the end of 2019 to 57% in mid-2021. So that's going up by 16 percentage points in just a year and a half, which is pretty remarkable. You can also see that the facilities with limited services declined over the same period, but there's a small number of facilities, about 2%, that still had no services, and that remained pretty stable. Okay, if we turn next to water, as the other service area where we have enough data to make global estimates, we can see that in 2021, 78% of healthcare facilities had water available from an improved water source on premises, and the remaining population was split evenly with 11% limited services and 11% with no service. If we look at the regional distribution, we see lower coverage in sub-Saharan Africa, just about half, 52%, and much higher at 90% in Eastern and Southeastern Asia. So there's a big difference, though, between having an improved water supply and having a basic water service. So the definition of basic water service means you have improved water supply, but that water is actually available and that improved source is located on premises. So this graph shows the gap between improved, that's on the right, the hollow circle, and basic, the filled circle on the left, and it can be very large. If we look, for instance, at Iraq, their census in 2021 found that nearly all healthcare facilities had improved water supplies, and they were pretty much all on premises, but water wasn't actually always available. In fact, in a quarter of facilities, water was available for less than 5 days per week. And we see this often in countries that have emerging piped water systems, but not yet continuous and can be highly intermittent. On the other hand, if we look down at the bottom of the graph at Sudan or Sierra Leone, the limiting factor is really where the water supply is located. That's the X. On premises, it's quite low. So in both countries, over 80% of healthcare facilities had access to an improved water source, but it's most often a borehole or a protected dug well that isn't located on premises. So it makes it difficult for healthcare workers and patients to get all the water that they need when it has to be brought in from outside. Back to the website, we saw earlier how to make a rank chart about basic water services, but there are all these controls on the left-hand side of the screen there. So you can also look at improved supplies, or those elements of the basic services, like is it available on premises? Is water available when needed? You can also select different regions. So here we're looking at sub-Saharan Africa and looking at the proportion of healthcare facilities that have water supplies located on premises, improved water supplies on premises. So again, you can find out a lot of detailed information by navigating this data portal on your own. Environmental cleaning, that's the newest of the WASH service ladders. It's also very closely tied to infection prevention and control. And because it's new, we don't have as much data on it. So the definition here is just about having basic protocols for cleaning available and having staff that have cleaning responsibilities that have all received training in how to conduct the cleaning. And when we made our first baseline report in 2019, there were only 4 countries with national data on environmental cleaning. So it's now gone up to 21, which is great, but it's still not enough to make any kind of global or regional estimate. But we do have countries from different regions in the world. So we can see that in many countries, protocols for cleaning are not available, or if protocols are available, there's not always staff responsible for cleaning or who have received training. So here you can see, for instance, that in Northern Africa and Western Asia, we have a really widespread. We've got Kuwait at 100%, and Sudan having only 1% of facilities having basic environmental cleaning services. So because there are 2 elements to this indicator, there's having the protocols and having the training, one or the other of them can be the limiting factor. And this graph shows that sometimes it's the availability of protocols. So in the upper triangle, you see Bhutan there, where about 45% of staff are trained, but only about 20% of facilities have protocols. So they're trained, but without protocols. Whereas in Rwanda, then this is a more common scenario. Protocols are available, but either people aren't identified who are responsible for training, or they haven't received training according to those protocols. Let's move to healthcare waste management then. The service indicator here has two components also. It's about having waste being safely segregated at the point of generation into at least 3 bins, and having wastes, both sharps and infectious wastes, be treated and disposed of safely. And again, here you can see one or the other of those could be the limiting factor. This graph also shows the income level of the countries. So you can see coverage is quite high among the diamonds and the squares, the high income and the upper middle income countries. But there are a lot of middle income countries, middle, upper middle, lower middle, squares and diamonds, squares and triangles, where waste is segregated, but it's not safely treated and disposed of. And one reason for that is that there's an awful lot of burning that goes on, open burning in middle income countries, and that doesn't count as safe treatment for global monitoring, but we do find that that's very widespread. But there are also countries where waste is being treated without being segregated. So on the far left there, you can see the Democratic Republic of the Congo and Guinea-Bissau, where there's almost no segregation at all, but about half of healthcare facilities do have some systems for treatment and disposal. This is often incineration, but of course it's inefficient to incinerate non-hazardous waste along with hazardous waste. It's wasteful. It's also dangerous because, especially in lower temperature incinerators, toxic furans and dioxins can be formed when plastics like that are burnt. Going back to our web page here, our data portal, this is an example of how you could look among least developed countries and see the different levels of service for different types of facilities. So we can look at urban or rural facilities. This graph is showing government facilities, and we had about 24 countries globally that had data on basic services in government facilities in LDCs. So that's about half of LDCs. There were only 12 LDCs that had data on non-government facilities. And where we do have both of them, we often find that conditions are better in non-government facilities in the same country compared to government facilities. I mentioned that there was a lot of open burning. Here you can see from, what is it, about 10 or a dozen countries. All of these orange colors here are some kind of open burning in a pit or on the ground without protection, or just open dumping. That also doesn't count as a safe treatment and disposal practice. The red ones, whether it's removing something off-site or dumping it without burning in a protected pit or ground, that counts as safe management, or incinerator. And ideally, we would like to see incineration in a 2-chamber industrial incinerator with controlled and high temperatures. But for global reporting, we also take more simple 1-chamber incinerators. So the last and the most complicated of the 5 services is the sanitation. So you can see just from the definition that there are lots of factors here. We're talking about having improved sanitation facilities that are usable, but also where there's at least 1 toilet dedicated for staff, a sex-separated toilet that has menstrual hygiene facilities, and at least 1 toilet accessible for people with limited mobility. So the figure on the right shows all those different criteria, and you can see that a lot of healthcare facilities on the left have some kind of sanitation facility or improved sanitation facility. But as you get to the right, the coverage really drops off. And it's often, especially having facilities accessible to those with limited mobility, or having menstrual hygiene facilities where the coverage is the lowest, and that ends up determining the basic sanitation service level. We don't have enough data to make a global estimate here, but we do have enough coverage to provide regional estimates for 3 of the SDG regions. And you can see quite low coverage, even in Northern Africa and Western Asia, less than half of healthcare facilities having basic sanitation, and only 13% in sub-Saharan Africa. As a quick example of going beyond the basic service levels, people are sometimes surprised to see how much non-sewered sanitation there is in healthcare facilities, even in hospitals. But this graph shows on the kind of the right half there, septic tanks and improved latrines, and on the left, sewer connections. And in most of the countries with data, these are low and middle income countries primarily, on-site sanitation is much more prevalent than sewerage sanitation. And I wanted to just highlight these 4 countries here that have only about 8–10% sewer coverage, but something like 40, 50, up to 90% coverage with on-site sanitation facilities, because we had a little bit more data here to show how things were managed in those settings. So if we start with Oman on the top right, everything's great. All of these on-site systems were safely emptied and taken to treatment. Oman's a high-income country. But if you look at all the other 4 of them, there's a really small percentage, it might be single digits, it might be 20% where the tanks are safely emptied. A lot of them, they're just not emptied at all. And of course, there's something wrong in the design and operation of a septic tank or a pit latrine if it's never been emptied in a healthcare facility. These things need to fill up. You also see that safe emptying tends to be higher in hospitals compared to non-hospitals, smaller healthcare facilities, also higher in urban than in rural areas. Okay, so then just to conclude, that's a lot of different service levels. People sometimes want to know, well, what's the overall WASH figure? And we haven't been able to integrate all 5 of them, but there are some regions where we do have 4 of the ladders. So least developed countries, fragile contexts, and sub-Saharan Africa. And they all look more like this figure, which is for LDCs, where water is the highest. Hygiene and waste management are maybe a third, and sanitation tends to be the lowest for the basic indicators. There are 16 countries where we do have all 5 ladders available. You can see them here. And that same basic pattern follows. Basically, the basic water service level is just an easier service level to reach than, say, the basic sanitation or even the basic hygiene service level. So we consistently see this pattern where basic sanitation tends to be the lowest. But in some cases, environmental cleaning can be the lowest. There can be some really interesting distributions. So the types of interventions that would be needed to accelerate or to improve WASH in healthcare facilities could be very different depending on which service levels tend to be better or worse in a given country. So with that, let me turn it back to Lindsay, and I'm looking forward to having a discussion about not just monitoring these things, but making use of the data and improving services in countries all around the world.
Thank you so much, Rick. Big round of applause here.